Good morning, everybody. Thank you very much, Joe, for the introduction. Distinguished guests and faculty, thank you for giving this opportunity to talk at this conference. The topic that I'm going to talk about is about the mechanical surgical options about post-cardiotomy cardiogenic shock. These are my relevant disclosures. And also one thing, there will be some off-label use of products, specifically about the duration of use. So when we talk about shock, I think first we have to talk about the shock registry. And everybody is pretty familiar with the data from the shock registry. It basically shows that 78.5% of these patients come in a left ventricular failure. So I'm going to focus on a few things about post-cardiotomy shocks. Out of the shock, a small percentage of those patients. So how about let's define what is PCCS. It is seen in patients who actually have undergone CPB, and it could be as a result of myocardial stunning, hibernation, and less poor protection. The incidence is somewhere around, depending upon which paper you study, it is about 2 to 6%. At our center, we are very biased. We think we have less than 2%. It's based probably biases because of patient selection. We don't take those patients that are dead. The other one is that it rapidly leads to multi-organ failure. How do people die of PCCS? It's because of multi-organ failure. They die piecemeal. And survival to discharge is highly variable. As what Ari was just saying, you got to see, each center will tell very differently. What support mechanism do we have for these kind of patients? It can be divided into two categories, the short term and the long term. And it all depends upon your local flavor, what you have, what your administration is ready to buy, and what your cardiologists are ready to invest in. So it could be balloon pump, Impella. Now Impella is actually an Impella family. You know, it is 2.5, CP, RP, 5.0, LD, Tandem, Centrimag, and any other roller pumps that you can use as an ECMO. Long term, you have various ventricular assist devices as well as TAH. Starting from the basic, I think, all of us use balloon pump. It is most commonest go-to device, spinal reflex, put it in almost all institutions in the United States have this device. So people blow it off as balloon pump, but I think this is the most important device because that's omnipresent. Every institution has it. Indications, all of you guys know very well. Contraindications are changing. Aortic insufficiency used to be, so now we are saying severe aortic insufficiency. More all the time, moderate insufficiency. We see that these have been placed and been transferred. Patients who have ASAI have this placed all the time. Dissecting aortic aneurysm still has been placed. I recently had a transfer from one of our outlying institution. Patient in a cath lab had probably appeared to be a catheter-induced aortic dissection, and patient was going down, spinal reflex, balloon pump placed. Severe sepsis, no longer a severe contraindication, I would say. The mechanism, as you all know, it helps in basically unloading the heart. It inflates at the diaphragmatic notch and basically helps in increasing the intra-aortic volume and pressure. Most important thing, what does it cause? The effects. It decreases the wall tension and ventricular work and increases the coronary and cerebral blood flow because that's the most important. The coronary flow happens in diastole, and that's what it increases. Complications, a lot of them, what Ari was saying, any mechanical complications placed peripherally will have this, the number one being limb ischemia. At our own institution, we have at least close to about, maybe Bob can correct me, at least 100 implants of intra-aortic balloon pump yearly, and we see about 2 to 3% of problems. Last week, I placed a LVAD and patient had a balloon pump. We removed it, and an emboli happened. Immediately, addressed, no issues, but yes, complication. Balloon rupture, less and less are being seen, extremely rare. So now let's go to some scientific data. What is the data that is out there about the use of balloon pump in cardiogenic shock? Cardiogenic shock, we're talking a little more global picture rather than just the PCCS. If you look at it, it did not significantly reduce 30-day mortality in patients of cardiogenic shock. These patients are in bad shape. Their outcome really does not change significantly because most of the time it happens of the timing when all these mechanical devices have been initiated. The mortality was similar. They did not have any clinical significance. So between the control who did not get it versus the patients who got the mechanical support. A randomized control trial, which basically shows that how do we do the safety and efficacy of percutaneous devices versus a balloon pump, came out of the German guys. And if you look at it, a lot of now mechanical support literature says cardiac power index. And this is now comparing at that time 2.5 of Impella, which is kind of slowly getting phased out to the minimum of CP, which provides about 3.5 liters of flow. So they compared that with the balloon pump, as you can see here. The second graph shows the time course of serum lactate between the two groups and the time course of free hemoglobin, plasma-free hemoglobin, because there is going to be some kind of hemolysis with any of these devices. So as you see, that obviously there is significant improvement with the more powerful devices. Multi-organ, dysfunctional score between the two groups, pretty much same. Sepsis-related, pretty much same. Overall survival curves of the Impella and balloon pump, if you look at it, I mean, they're different, but initially, most of those patients still die. So I think it was a very good paper. This is another paper that came out, and this paper was showing basically, yes, the percutaneous devices really helped in increasing the hemodynamic support of these patients, but it really did not change the initial early survival. And that's something that we all need to understand, that the initial survival is still remaining poor. We have not conclusively yet reached a stage that we can say, okay, this is level A evidence that you need to use these devices for shock right away. Because all the time we get a question, hey, we don't have this kind of a device, but we have this, what do we do? And we always say, whatever is the biggest and best device you have and the ease with which you guys can place, please put that in. If it is a balloon pump, no problem. There was a very interesting paper that was published in the Dutch literature. It was a farewell of balloon pump. I think, and I would outline this for a specific reason, because everybody's tried to show for so many years that intra-aortic balloon pump is going to really change and impact, and has become kind of nobody thinks about it and places it. And a lot of studies in the 70s and 80s and 90s still continue to show that. But I think we always, we've come to learn actually that the surrogate endpoints such as cardiac power outputs for cardiogenic shock really is not the only thing, okay? These devices should be tested in a randomized fashion. And the problem is we do not have trials to randomize, okay, patient A is going to get a balloon pump, patient B is going to get a CP, patient C is going to get a Impella 5.0, and patient D is going to get a VV or a VA ECMO. So that's the problem of all of these problems. We'll talk about Impella 5.0. I mean, there are different ways of placing Impella 5.0. Some can place in post-cardiotomy shock right when the chest is open through the ascending aorta. Can be placed Impella through the groin, 2.5 and a CP. 5.0 can also be placed through the right axillary artery approach. If you look at what is published for post-cardiotomy cardiogenic shock on patients with Impella, not a lot of studies recently have come. If you look at, you say, no, there are a lot of studies there. Yes, they are. But for post-cardiotomy shock, not a lot of studies still exist. I had the privilege of working with Dr. Siegenthaler, again, out of Europe, and he joined at Pittsburgh for many years. And their results, the venability, 56%, survival, still about 37%, as what Ari was saying. Just remember that rule that he was coming up, 60-40-30. This is our experience at OCHSNER about the 5.0. we use that as a go-to device for bridge to decision. And we've published that at the ISHLT, as well as the manuscript has been accepted, and it's going to be published in the fall. And we now have 40 Impella 5.0 patients that have been implanted exclusively through the right axillary artery approach. And for this study, we had 17 patients of those 71%, because we had 24 patients in that study at that time, were on, 100% of those patients had balloon pump, and 71% had balloon pump discontinuation after this. All these patients were intubated, were on multiple inotropes. So we thought of doing it a little differently, because we were saying is, hey, everybody talks about cardiac power index, this and that, and we start showing that, okay, the serum lactates, but what does it really impact our end organs? Because that's the most important thing. The creatinine was 4, or they were anuric when they came, the LFTs were through the roof. So we said, why don't we use MELD? MELD is a composite score that looks into the kidney function and the hepatic function. That's how you get a liver transplant. If you are MELD of 12, you are listed on a liver transplant list. So our average pre-op when these patients are coming in shock is 21, and post-op, after the implantation, yes, they're still not perfect, but they're down to 14, and this is statistically significant difference. Average duration of support, so this is off-label again, is almost close to 18 days. It's not approved for 18 days. It's in US, Impella 5.0 is approved for 6 hours, and CE marked in Europe for 10 days. Our longest support has been 71 days. Patient's characteristics, the usual that everybody actually sees around, EFs low, a mechanical ventilation, 100% of them, inotropic support, balloon was already in. And our outcomes are 87% extubated, 100% balloon removed, survival to discharge, 62%. 30-day was a little better. One patient died during an intervention of draining a pleural effusion that resulted in a bad problem. What was the end? Recovery in about 25% of these patients. So again, to what Ari was saying is the rule, 60-40-30. We could not actually get them to recovery. They needed something. And a majority of them, 40%, all of them, ended up going to an LVAD. Heart transplantation was possible for 2, and death happened on almost 30% of the patients. If we go down to the next option of, post-cardiotomy shock patients, what other options? Obviously talking about ECMO, a little bit about the basic principles that most of you actually in the audience know it very well, and you guys taught us. So I'm going to skip on that. And it's kind of what same things that Ari had mentioned about. Basic design of the pump is the centrifugal Biomedicus, cheap. Want to go to a little expensive one, Centrimag, Rotaflow, less hemolysis. Try to keep the negative pressure in the inflow line less than 100 to prevent hemolysis. And oxygenation is basically based on O2 and CO2 exchange at the interface between the gas and the blood. And commonly we talk about sweep. It is the flow rate that determines the CO2 removal, and FiO2 determines the oxygenation. Various configurations, VA, VV. What are the advantages of each? Very straightforward. It depends upon what you're achieving. People say that ECMO, the criticism of ECMO is that it doesn't do a very good LV decompression. That's not true. Peripheral VA ECMO does not do a good decompression, but a central VA ECMO can do an excellent central decompression. But obviously, advantages and disadvantages exist. It's much more invasive. Sternotomy has to be performed. These patients are in shock. Their hepatic enzymes are all over the place. Coagulation profile is pretty skewed and have a lot of complications from bleeding. Whereas peripheral, you can actually do a lot without doing encountering any of these complications, provided you provide a distal perfusion catheter. Good quality data is always lacking, as we all talked about. And this is the almost same slide from the ELSA registry. If you look at it, respiratory 55, 39, CPR. So the 60, 40, 30 rule. This was actually a very good study that came out of the perfusion group, and this is from 2006, 15, I think, almost end of that. And they said that what happens to these patients who are going for this PCCS patients, going for these ECMO, and what are their outcomes? So they found risk factors. The risk factors were very important. You know, a lot of other places, other papers kind of tell few, but they actually came up with the actually ones that are clinically more relevant. If you are having a CPR, where if your pH is less than 7.1, if your lactate is greater than 12, obviously old individuals don't do well, and norepi levels greater than 0.5 mics. They said that the main cause of death was sepsis because obviously long duration of stay in the hospital, these devices are getting better, ICU stay is, management is getting much better, so they kind of don't die right off bat, but die from a little different complications. 58% wean, discharge 30%, hospital mortality 70%. Same, hasn't changed over so many years. There's a nice paper out of the guys from UK about the ventricular assist device therapy in post-cardiotomy shock. And as you can see, they also have the same, and they've used actually different devices. They had the Sorin, the Levitronics, the Biomedicus, and all of them. And their results, no change, no change. Short-term ventricular assist device in post-cardiotomy shock, also same, nothing has changed whatsoever. Advanced mechanical support for 20 years analysis in a non-transplant center, which is actually very important because transplant centers have a little more other options available. And their survival at 30 days, 37.5%. And this is very recent. This is not old paper. Survival to discharge, 31.2. Same thing about ECMO. This is guys from Fred Moore. 517 consecutive patients treated with ECMO for refractory results, as you guys all say. Very similar graphs in almost all studies, almost all centers, whether you take it UK, you go to other European countries, you take the Cleveland Clinic, it's just same. The Cleveland Clinic guys, Cosgrove and all of it from that time frames, Nix, Madera, same results. I think the key of any of these things is time of initiation. I think that if you start teasing out, the results look dismal because a lot of centers and a lot of individuals, even on those great centers, have extreme variability of practice. We all in the operating room keep on, oh no, rocket fuel will work, rocket fuel will work, rocket fuel will work. Well, rocket fuel will work to take the patient to celestial discharge, for sure. And that's what happens. If you initiate right up front, you actually give your patient a fighting chance. I mean, if you are in PCCS, it's never going to be good. So, other temporary devices we were talking about is the devices, Levitronics, which is now Centrimag. The advantages, disadvantages, you already know. Various combinations and permutations you can use for cannulations, for univentricular, biventricular support if you want. It is very nicely done. I would say tunnel it subcutaneously as low as you can so that you can close the chest. Close the chest with 3 sternal wires so that bone approximation happens, less chances of bleeding happens, you'll have excellent results. You can have patients who are ambulating. If you look at just for them, there are different studies from them. Venability, 52%, survival, 30% for Levitronics, Centrimag. Similarly, if you go for the post-cardiotomy for ECMO, more studies, when I start comparing them, same results. This is only for historical significance. No longer, I think from end of this year, Thoratec/St. Jude/Abbott is going to stop production of all of this. Tandem heart, it deserves a specific, I think, mention. It has significantly improved. It's a centrifugal pump that requires a septal puncture. Yes, it requires more specialized cardiac interventional help, where our cardiac interventionalists are getting better and better at more and more institutions in peripheral organizations, and they're able to do these things. You can have a percutaneous LVAD, you can have a percutaneous RVAD. Now they have come up with a newer cannula that enables you to actually not even go through the groin, all double lumen, flexible cannula that goes through the neck. We are all saying about all of this thing, and we are talking about, things are not improving, things are not, the results are, but there is some glimmer of hope, I would say, that things over time frame, and this is 95 to 2004, we have started to see some improvement. Yes, it is not consistent with what a lot of other centers see, but I think the results are different because we tend to utilize these devices a little later. If you tease out those results, you'll start to see actually we are doing much better. If you start looking at mortality, the mortalities have changed from 60% now. Best data that is going on is showing survival of almost up to 60% in these kind of patients. See, the 60, 40, 30, the 30 group is now almost coming at individual centers to high numbers. Yes, there could be a bias, but it can't be a bias of doubling those survivals. So we have to take into consideration which centers are doing that and who are the guys. The guys who are completely dedicated in the MCS are actually going to do it and going to be very aggressive right off bat. They're not going to wait for a distal perfusion catheter to be put in later. They will put it in the same setting so that the limb complication rates don't happen. Fasciotomies don't need to be done. They'll run their ACTs at a much lower rate. A constant battle happens at our institution with our perfusionists about the ACTs versus PTTs and how much we need, because bleeding complications are significant, and bleeding complications have significantly dropped down because we are saying, and we have a perfusionist group here, you can ask them, first 8, 12 hours on VA ECMO, or even sometimes up to 24 hours, not a single drop of heparin will be given. We would not give. No matter how many hate emails have been sent by our chief perfusionist, but it's okay, And they're right too. And then we gradually start. But our bleeding risks have significantly dropped down. There's not a single study in whole medical literature that says blood transfusion is good for health. So it is an independent risk factor. Just forget about MCS or anything. Independent risk factor in all studies across all patients. Blood transfusion increases mortality, period. So that also has to be taken into consideration. Permanent devices we need to talk about. Post-cardiotomy, I don't think so has any role of permanent devices. They have a role once we have salvaged these patients, because not all of them would be able to get away with recovery. So they'll need something. These devices are just getting better and better. The survivals have just going through the roof. Now, a lot of centers, including ours, we have 5 years out many patients, not one, not two, supported. Longest is actually no longer 7.5 years. It's, I think, if I'm not mistaken, that lady died at University of Michigan after 9.5 years of support from a single device. Hardware, smaller configuration, TAH, that could be used. And actually, TAH still has a role in some centers for acute post-cardiotomy shock. In patients who are in complete biventricular failure, they actually use these patients because these patients tend to have a lot of arrhythmias. And arrhythmias, unless until you provide biventricular support systems, a univentricular support system is not going to really help you. So they kind of still do it. The only thing is that they are limited by the size because it's a 70 cc pump. Recently, the trial for 50 cc pump has started. That would enable a lot more patients to get into that. HeartMate 3 is right now in the Momentum 3 trial. So I won't just discuss a lot, but only advantages are that what we have learned from HeartMate family have been rectified, and newer things have been added to the HeartMate 3. So that I would bring to the end of my talk about this cardiogenic shock in post-cardiotomy. And thank you very much for giving this opportunity.
Have a seat. Plenty of questions.